Aloha and welcome to our lecture today. We are going to discuss tracheostomies. Tracheostomies are an artificial airway that sometimes need to go into our patients for many reasons. However, before we get into the discussion about tracheostomies, we kind of need to talk about endotracheal tubes, okay? And so let's go ahead and get started. When a patient comes into the emergency room in respiratory distress, and it becomes apparent that that patient needs to be intubated, meaning that we need to get them an artificial airway because they are not getting enough oxygen, okay? Then the first thing that will happen in that emergency situation is that they will be intubated. So here in the images we can see a laryngoscope and we can see an endotracheal tube or an ET tube. Okay, and this tube gets put in through the mouth, down through the vocal cords and the trachea and into the lung, and then we can either bag the patient with an ambu bag or we can hook them up to a ventilator. But here's the thing, an endotracheal intubation and an ET tube as an artificial airway is not a permanent situation. It can only be used for a temporary airway because the ET tube cuff causes damage to the lining of the trachea. Okay, it occludes blood flow when it presses up against the lining and it causes damage. So if a patient needs to be intubated for a longer period of time, a tracheostomy will be performed. So let's kind of go back quickly here and look more carefully at our ET tube. See at the bottom of the tube there is a cuff and it is inflated. So once the tube is inserted, the cuff is inflated to give some gentle pressure, right, to keep the tube in place and also to keep the air in the lungs once the artificial type of ventilation is being done, all right? So that's the purpose of the cuff. However, like I mentioned, the cuff causes damage, and so this is just a temporary fix. If we need to move to a more permanent type of artificial airway, we need what is called a tracheostomy. And this is a hole in the windpipe or the trachea created by a surgeon, and it's called a stoma. And it replaces their nose and mouth as their pathway for breathing. So here we can see the tracheostomy tube. This is inserted into the stoma to keep the hole open and provide an entryway into the lungs. And so this trach tube is also referred to as the outer cannula. This is performed to provide an airway in people who need mechanical ventilation, people who are having trouble swallowing or maybe at risk for aspiration. We use a trach tube to bypass an acute upper airway obstruction or a chronic upper airway obstruction. So let me give you an example. In a trauma, right? If a patient comes in and, you know, they've had some crushing injuries to their face and their nose and their mouth and their upper airway has been compromised, then they might need to have, to be intubated and then to get an ET tube and then to get a trach when they go into the ICU during their healing period. Right? And then after they heal and they come through the trauma, if they heal up nicely, it can all be reversed and they can go back to breathing from their mouth and nose once their injuries have healed. So other indications are following a severe stroke for airway support. If a patient has had a severe stroke and is in the intensive care unit, they may get a tracheostomy. Other times that we utilize this is when a patient is unable to cough up their own mucus and provide an easy way to suction mucus from the lungs. So for example, cystic fibrosis exacerbations, chronic bronchitis, and of course in the case when an individual is unconscious or in a coma. So here are some of the parts of the tracheostomy tube. We're going to talk more about the tube and the equipment and what we call everything in detail. But more importantly, in this image, I want you to kind of focus in on where you see that tracheostomy tube going in, and how you see it in the trachea, right? And then right behind the trachea, we can see the esophagus, right? So that's our food pipe, right? We have our windpipe, which is our trachea, and then we have our food pipe, which is our esophagus, okay? And so it's very important that that trach is in the right spot, which is in our trachea, which leads to our lungs. So when this trachea is put into place, there's an incision made below the cricoid cartilage in between the tracheal rings. And usually it's somewhere around the second and third tracheal ring that the tracheostomy tube is inserted. So in this image, you can see how the tube is inserted and how it sits inside the trachea. We're going to look at a few parts here in more detail. We can see the outer cannula, right, or the tracheostomy tube. We can see the trach cuff, because the trach also has to have a cuff in order to anchor it into place. And also while the patient is being mechanically ventilated to keep that air in the lungs. We have an inner cannula, which we'll talk more about in a little bit, which can be removed. It can come in and out and be cleaned. And then we have an obturator, which is what we use when the outer cannula is placed. And so notice the obturator has a smooth, rounded tip, and this protects the inside of the airway from damage while the outer cannula is being inserted. So it's really important to always have an obturator at the bedside when you have a patient with a trach, because if the trach were to be expelled, the patient would no longer have an airway. And if a new trach had to emergently be put in, we would need an obturator at the bedside in order to do that. Okay, so that's important for nurses to know that. So the cuff, it's necessary, as I mentioned before, when a patient's on mechanical ventilator. Inflating the cuff during mechanical ventilation helps assure that that air is entering the lungs and not escaping through the nose and mouth. The cuff also prevents aspiration of saliva in patients who have trouble swallowing. But again, that cuff can cause some damage as well, right? Still that risk for damage to the lining. So we want to keep that cuff pressure as low as possible, all right? And we also want to relieve that pressure every so many hours while the patient is under our care. So again, it's stated here in this slide that it will cause damage, and the cuff does need to be deflated for a certain number of hours to prevent that damage to the tracheal lining. So in this image, we can see both an inflated cuff and a deflated cuff, right? We're going to talk a little bit more about the parts as well moving forward here. So again, I mentioned inflated cuff indication would be to prevent pulmonary aspiration, right? So when a patient does not have pulmonary toilet, meaning that they are unconscious They don't have a cough reflex. What we don't want to happen is to have those aspirations, to get an aspiration of secretions that could be coming from their esophagus, coming from the lungs. They can't cough that out, right? And then all of that in the lungs puts them at risk for infection, right? For pneumonia. And so we want to try and prevent that from happening. The outer cannula is connected to a flange, which is held in place, oftentimes with a Velcro strap that wraps around the patient's neck. We're going to look at parts in the next slide. I really want to make a point here right now that Velcro strap is extremely important, and that when you are changing out a trach, and maybe you are doing trach care and the trach tie or the Velcro strap has been soiled and you want to change that strap, one rule in nursing is that we never remove the old strap until the new strap is in place, all right? Because that strap is anchoring that airway onto the patient's stoma, all right? And so when that becomes released, there's a risk for that trach coming out. So we always want to make sure that we replace the new trach ties before we remove the old trach ties. So here are some parts labeled for you to review. I will go through them very quickly. Number 1 is the outer cannula. Number 2 is our inner cannula, which we mentioned fits snugly and can be removed for cleaning if there are mucus plugs in there. The number 3 is the flange that fits against the patient's neck. This is attached to the outer cannula or trach tube, which then again connects to our Velcro straps. Number 4 is our outer diameter, which connects to our ventilator or our respiratory equipment. So that's the connector for either our ambu bag or our ventilator. Number 5 is our cuff, we mentioned, that anchors the tube and provides a seal so that air doesn't leak during mechanical ventilation. Number 6 is called the air inlet valve, which allows for air to be injected to inflate the cuff. And number 7 is our air inlet line. Number 8 is our pilot cuff. And so this serves as an indicator for how much air is in the cuff. Remember, we said we didn't want the cuff to cause too much pressure. We wanted the cuff to have just enough pressure in order for it to do its job, because excess pressure in that trachea is going to cause more damage. Number 9 is fenestration. It's a hole in the tube that allows airflow in and out of the trach. And number 10 is a speaking valve or a button or a cap, all referred to as those names, a speaking valve or a button or a cap, which occludes the trach tube opening while giving the patient the opportunity to then speak. So, what should be at the bedside when you have an individual who has a trach? Definite spare tracheostomy tube. Definitely a spare inner cannula, which is the same size and type that fits into the trach tube. We talked about having a tracheal obturator at the bedside as well, just in case the tube becomes dislodged and needs to be reinserted. We also need to have properly working equipment at the bedside, right? We're going to need a trach suctioning kit that is sterile at the bedside. We might need to have humidification equipment at the bedside as well, because sometimes we need to have some moisture there because secretions can tend to become dried out. The other important thing here is our suction equipment. Very important. If a mucus plug occurs, we need to be able to go in with our suctioning equipment and suction out that trach and get that mucus plug out, because it could be actually impairing that patient's ability to get air into their lungs, okay, and impair their gas exchange. So we need some sterile gloves, we need a sterile suctioning kit, we need our suction machine, and we also need some sterile water as well. Okay, so we're going to learn more about suctioning a trach tube in a different talk, but the purpose we mentioned before is to maintain a patent airway by removing endotracheal secretions. Suctioning is performed, though, only as needed. So you will not have an order from a physician or another provider to do this at a preset time. You will only suction a trach based on your assessment of the patient, meaning that maybe their SpO2 has dropped, maybe you're hearing a lot of adventitious lung sounds, maybe the patient is, her respirations have increased, right? So you're assessing your patient, you're identifying that there may be a reason why they're not getting airway circulation of air, and that you need to then make the decision to go in and do some tracheostomy suctioning. All right, so here we can see the trach tube. We can see in this image that we've got our trach tube, we've got mucus building up in the trach tube, and then we have our suction tube going in, and that will clear that trach tube of that mucus buildup so that our patient then again has good gas exchange. And so other type of care that we do in tracheostomy care is to clean the inner cannula and the stoma and the site, and to change the tracheostomy ties. So this is a trach care kit. And this is, again, to help maintain a patent airway by removing that inner cannula and cleaning it sterilely, and then inserting that back in. And again, that's going to be a separate learning experience where you'll learn how to do the trach care. You'll practice doing the trach care in lab. Okay? The important thing when you're doing either trach suctioning or trach care is, number one, to realize that the patient might need to be oxygenated supplementally while in between your suctioning, with probably an ambu bag at the bedside. The other thing you want to remember when you're doing any type of suctioning or trach care is to be very gentle with the trach and make sure that it is not dislodged, because remember, once that trach tube comes out, the airway is no longer open. Okay? So we talked a little bit before about the fenestrated tubes. It helps facilitate and improve speech. The hole allows an increase in volumes of air to be forced up through the larynx during exhalation. It also helps improve swallowing function, restoring a more normal airflow, and restoring some of the protective mechanisms of the normal swallow. So as we are weaning our patients from their ventilator, hoping to get them off the need for having a trach, we want to start, developing their ability again to swallow, and so part of that process takes place in that weaning. So the fenestration also allows secretions as well as air to pass up and down the patient's airway, and if needed, sometimes we can give the patient a sputum container or tissues for secretions. So these are often used for weaning, and when we say decannulation, That means to take the trach tube, yes, to remove the outer cannula, right? So to remove the trach tube is to decannulate the trach. Okay, so decannulation can happen purposefully because you've successfully weaned your patient from the trach, or accidentally by the patient coughing, the patient pulling the trach tube out when they're confused, or it accidentally coming out just through manipulation, which is why we always want to keep those trach ties in place. So speaking. A speaking valve can be used by inserting the fenestrated inner cannula and occluding the tracheostomy tube opening by using one of the following: either the patient's finger, a speaking valve, or the plug, cap, or the button. All right, so here we can see the cuff sitting inside the trachea, and we can see that the cuff is deflated. And that is going to be the best way for the patient to be able then to start speaking. The cuff should be deflated, and then they need to plug that trach in order to speak. So this is what a speaking valve looks like. You can see the flange is still in place. You can see that the trach ties are still in place. Here we see an individual who is eating. Okay, so while using a fenestrated tube, it does restore some of the normal swallow protection mechanisms. The nurse should always be looking for signs of aspiration, right? And so here we see a gentleman eating a sandwich. It helps with enhanced communication. You know, when they're more awake and alert and oriented, we can reduce the sedation. They can eat and they can drink, start engaging more in their rehabilitation to get better. And we want to decannulate them as soon as it's clinically safe to do so, right? Because we want to get that patient back on track to get better, get that trach removed, and get them well on their way to be home and back to their usual patterns. Swallowing is further improved by having the cuff deflated and the trach opening occluded at the moment of swallow. Using that speaking valve can help strengthen that swallow, okay? So here's a speaking valve up close. It's got a movable plastic disc that opens on inspiration but closes on expiration, okay? This means that during expiration, no air can escape through the tracheostomy tube opening as it is redirected up through the larynx instead. All right. So here we can see that while wearing the valve, the patient will notice that air exhaling via the nose and mouth, speech is improved, full sentences are possible, expectoration returns to the normal route, and the patient's able to kind of blow their nose and sneeze as pulmonary toilet kind of comes back, right? Then actual secretions actually start decreasing because of evaporation of secretions as the air is exhaled. So occasional dryness of the mucosa can occur. And again, strong coughing can blow off that valve, right? So, and you know, it kind of takes some getting used to, right? So let's talk about dealing with emergencies, right? If the tracheostomy tube comes out, don't panic. The patient is watching you. The patient is looking to you to be there, to be confident, to be calm, and to be able to solve the problem, all right? So even though you might inside feel very anxious if something goes wrong with the trach, please try to stay calm and know this. Once the tracheostomy tube has been in place for about 5 days, the tract is pretty well formed, okay? And it should not suddenly close on you. However, we still have a medical emergency on our hands, right? So it's important for you to know that if that trache's been in there at least 5 days, that airway is probably going to still be open even if the trach comes out. It's almost like, you know, when you get your ear pierced, right? The hole's still there, even when you take your earring out, right? Now, is it 5 days for everybody? No, not necessarily. So what I'm telling you is that if it's a new trach, relatively fresh, and it comes out, you really have to monitor the patient very carefully, call for medical help, and get that thing back in there, all right? If the trach's been in for many, many years, clearly, you're probably going to be okay, all right? It's important to know these things. Ask the patient to breathe normally via their stoma while waiting for the doctor. You know, sometimes there's a stay suture, if present, or a tracheal dilator may be used to help keep the stoma open if necessary. But just stay with the patient, be calm, reassure the patient, let them know that help is on the way, okay? All right, so acute dyspnea. Dyspnea is when the patient is experiencing shortness of breath, right? Most often, it's because of a clogged trach. We want to ask the patient to try to cough. Sometimes a cough can expel the secretions, as long as the trach ties are in place, right? We can also remove the inner cannula. If there are secretions stuck in there, we can remove them, clean out that inner cannula, and then reinsert that. The outer tube, which does not have secretions in it, this will help allow the patient to breathe freely. All right? So sometimes we need to clean and replace that inner cannula, or we need to do suctioning. If coughing or removing the inner cannula doesn't work, we might need to get those secretions out that are lower down in the patient's airway, and we use the suction machine to do that. So again, here's our suction machine and our suction catheter kit. If these measures fail, right, so you've tried cleaning out the inner cannula, you've attempted trach suctioning, and you're still having problems with the patient's oxygenation status, you're going to want to commence a low concentration oxygen therapy via a tracheostomy mask. And you're going to want to call for help, right? Because there's something going on, right? You have, as a nurse, intervened. You have done several nursing interventions to maximize the patient's ability to oxygenate. It's not working. You need to call for help. It's possible that the trach may have become displaced. Stay with the patient until assistance arrives and prepare for a change of the tracheostomy tube. So that is my talk about tracheostomies. Of course, there is always so much to learn. I encourage you to get into your textbook, spend some more time learning, ask questions, get into clinical and practice these skills. And until next time, aloha.